All right, party people, we are back at it with some rheumatoid cardiology. Let's get it. So we have a female in her 40s. She has chest pain. The pain is worse on inhalation. The pain is also worse in a reclined position. When we look at her meds, she's on naproxen and prednisone. Shout out to her rheumatologist. Her blood pressure is 120/80, but during inhalation, it drops to 110/75. Based on this presentation, what will be seen on her ECG? So her x-ray immediately grabs our attention. Those yellow arrows are pointing to boutonniere deformities or boutonniere deformities. She's not throwing up gang signs. This is rheumatoid arthritis. I could have also shown you an x-ray of ulnar deviation to the same effect. Now, as far as the pain being worse in a reclined position, I also could have told you that she walked into the office bent over at the waist. You should be recognizing these signs as pericarditis. The hallmark of pericarditis is that the pain improves when the patient leans forward and is worse when they lean back. So this is a classic presentation. Now, her medications include naproxen and prednisone. This detail reinforces rheumatoid arthritis, in case you missed the obvious x-ray findings. Now, in terms of rheumatoid treatment, there are two branches of treatment. There's symptomatic treatment and disease-modifying treatment. As for the symptomatic, we're thinking NSAIDs first, then corticosteroids like prednisone. This helps symptoms, but does not slow disease progression. As far as the disease-modifying branch, aka DMARDs, you start with methotrexate followed by TNF-alpha inhibitors. These, in fact, do slow the progression. Now, as far as her vitals, the concept of her blood pressure being 120/80 while sitting, that then drops to 110/75 while she inhales, that is what is called pulsus paradoxus. This is a physiologic phenomenon where systolic blood pressure drops with inspiration. Now, for your licensing exams, pulsus paradoxus becomes important when the drop is greater than 10 millimeters of mercury. But let's clarify, pulsus paradoxus refers to the drop itself, regardless of magnitude. Now, I have seen questions where it's less than 10 millimeters of mercury, and they still call it pulsus paradoxus. The terminology just describes the blood pressure drop with inhalation, nothing more, nothing less. Now let's run through why this happens. Let's unpack this. So, you inhale, the diaphragm moves downward, intrathoracic pressure decreases, venous return to the right heart increases, there's increased pulmonary vascular compliance, more blood pools in the lungs, reducing left ventricular preload. This results in a temporary drop in systolic blood pressure. If the drop is greater than 10 millimeters of mercury, we're thinking cardiac tamponade. This is usually an acute pericardial effusion. So it could be due to trauma, like a stab wound to the chest, or left ventricular wall rupture, post-MI. In tamponade, we expect Beck's triad. Beck's triad is hypotension, jugular venous distension, as well as muffled heart sound. And again, a drop greater than 10 millimeters of mercury upon inhalation. Now, some students might mention here severe asthma or COPD can also cause pulsus paradoxus. That is true. However, for your licensing exam purposes, it's almost never tested in that way. When you see pulsus paradoxus, I want you thinking cardiac tamponade, not COPD or asthma. In terms of this question, what is being tested is not tamponade, it is pericarditis based on her posture and her symptoms. Now, you might be wondering, how does rheumatoid arthritis tie into this? So this is the key point here. It's that rheumatoid arthritis can cause pericarditis. Autoimmune diseases, in general, increase the risk of pericarditis. Rheumatoid arthritis can also cause pulmonary fibrosis. This is referred to as rheumatoid lung. All right, let's go through the other answer choices. As far as electrical alternans, this is seen in pericardial effusion or tamponade. This is where fluid movement causes alternating QRS amplitudes. This is not correct here since we do not have a tamponade. As far as irregularly irregular rhythm, this is AFib, atrial fibrillation. Not relevant here, but it could show up in hyperthyroidism. As far as no abnormalities, this would be the correct answer if the diagnosis were costochondritis. Now, if you did not have the x-ray and you didn't understand the concept that were being presented, this particular case may sound like costochondritis. But it's worth noting, for reference, if you have a patient with positional chest pain, especially when worsened with reaching overhead or behind the back, this is a classic presentation of costochondritis. Pain that worsens with a deep inhalation can certainly be costochondritis. It has to be in your differential diagnosis. It will show up on your licensing exams, and you have to be able to deal with it. Moving on to ST elevations in leads 2, 3, and AVF. These are the inferior leads seen in inferior MI, not consistent with this patient's presentation. As far as diffuse ST segment elevations, this is the correct answer because this is pericarditis. You'll see ST elevations in many leads, not just 2 or 3 contiguous ones like an MI. This is a hallmark finding. I could have also included PR segment depression as a correct answer. And quite frankly, this is actually more specific for pericarditis. However, in my experience, the USMLE rarely tests that specific detail. Diffuse ST elevations show up much more often than PR segment depressions. All right, that's it for this question. Go crush it.